Hi, everyone. Welcome to the expert briefings for 2022. Sorry, 2021-2022. I'm Dr. Jim Beck, the Chief Scientific Officer at the Parkinsons Foundation. I'm delighted to welcome you to our expert briefing series. Today, we kick off our series with an important topic, the Parkinson's journey, understanding progression. So one thing I'd like to do is we start with our Zoom presentation. I know that many of you are familiar with it, but just go over some technical reminders about how our Zoom webinars work. So if you look within your Zoom screen, there's going to be a couple different buttons along the bottom, and one of them is for the Q&A. So during our presentation, you can think about the questions that come to your mind that are brought up by the speakers. I encourage everyone to use the Q&A in the bottom feature to ask your questions of the presenters. My colleagues and I will go through these questions, ensure that they're relevant to the topic at hand, and do our best to answer them all. My colleagues on our helpline, of course, can help answer any questions that we don't get to during our webinar today. So if there are other things that you might want to ask, feel free to ask them in the Q&A or even call our helpline afterwards. During the presentation, my colleagues will be using the chat feature to push links to various information, such as information about the slides if you want to download them along those lines as well. So for our next slide, I just want to remind everyone what the mission of the Parkinson's Foundation is. We are really the nation's leading community for people who live with Parkinson's disease, the people who love them, and all of those who are working to end the disease. It's with our presence in communities across the country, not only via webinars, but also in person with my colleagues and across the globe, we believe that a promise of a cure and a better life today can be achieved by our work and with your support. Our goals of the foundation are really very straightforward. And we have this credible urgency to our mission. So that translates into improved care for everyone with Parkinson's disease, advancing research towards a cure, and empowering and educating our global community about Parkinson's disease. And I think we hit on many of those pillars today in our call. So I would like to move on and thank our sponsors, Genentech, which has provided an unrestricted educational grant to the Parkinson's Foundation and allowed us to present this expert briefing series. Without their support, we wouldn't be able to talk to you today as well. So as I mentioned, we are recording this episode, so if you've seen this and you want to go back, we'll have a link available to do so. If you have colleagues or friends who want to, you said, oh, this is a great webinar you should see, you can forward that link onto them as well. Our slides will be available for download, so if you wanted to have them on hand and look at them, you can do that as well. So there'll be a link sent in the chat on how to download a PDF version of our slides today. So for the next thing I would like to do, order of business, is really to get to know who is listening today. So a poll will appear on your screen, and I just ask everyone to just quickly fill it out and hit submit. This way we get a sense of who's here, and our presenters can be certain to tailor their presentation to the extent they can to represent who our audience is today. It's always very helpful with which to know that. So give us a few more seconds as we collect the data for these polls, and we'll get a chance to see who's actually listening today. We have a number of respondents. Most of the people are people with Parkinson's disease, and a lot of individuals with their caregivers as well. And it's interesting that we have a nice mix of individuals who have relatives touched by PD, as well as healthcare professionals as well. So welcome to our webinar today. So without further ado, what I'd like to do is just kick off our expert briefing series by introducing our experts today. First, I would like to move on and talk about Dr. Annie Killoran and Lance Wilson, who are our discussants today. They're our speakers. And joining us first will be Dr. Annie Killoran as our first presenter. She'll speak first, and then Lance Wilson will speak next. Let me tell you a little bit about Dr. Killoran. She's a movement disorder physician at the University of Iowa, which is a Parkinson's Foundation Center of Excellence. She completed her fellowship in movement disorders at the University of Rochester, and then became a faculty member at the University of West Virginia before joining the University of Iowa team in 2016. She's involved in the multidisciplinary Huntington's disease clinic and has dedicated clinics for ataxia and botulinum toxin, as you would expect of any well-trained movement disorder neurologist. However, the large majority of her patients have Parkinson's disease, and she's currently involved in a clinical trial targeting sleep dysfunction in people with PD. She established a specialty clinic which provides palliative care for patients with Parkinson's disease and other neurological symptoms. Joining us later in the program, as I mentioned, will be Lance Wilson. Lance is a licensed neuroscience medical social worker at Thomas Jefferson University in Philadelphia, which is also a Parkinson's Foundation Center of Excellence. He works with patients diagnosed with movement disorders such as Parkinson's disease and others. He works with both patients and their care partners, providing education, assistance, navigating healthcare systems, which can be rather troublesome, and ensuring a continuum of care for people who come through the clinic. Lance has a skill set to assess and facilitates interventions, as well as referring people to community and national resources like the Parkinson's Foundation. And he conducts brief therapies while offering support and guidance throughout the course of the disease to the patients at the Thomas Jefferson Clinic. So what I'd like to do now is turn this over to Dr. Annie Killoran and welcome her to the expert briefing. Dr. Killoran?
Thanks, Jim. Can I just make sure, is my screen, no, I guess my screen isn't being shared. Let's try that again.
And while Dr. Killoran is working to get her slides going, I just want to welcome our listeners on Facebook as well. Appreciate everyone's attention and participation in this. Dr. Killoran?
All right, are we seeing my screen?
Yes, we are.
We are, that's great. So thank you, Jim. Again, my name's Annie Killoran, and I'd like to thank the folks at the Parkinson's Foundation for inviting me to give this presentation to you today. And thank you all for joining us. Here are my disclosures. And today we'll be talking about the stages and progression of Parkinson's disease. As you know, Parkinson's is a neurodegenerative condition, meaning that it's progressive. It gradually worsens over time. But how do we measure the disease progression? It's not by blood tests or brain scans. Instead, we monitor people clinically by their symptoms. For example, if your medications aren't working as well as they used to, this might be an indication that the disease has progressed. We also base our progression monitoring on our findings on the physical examination. And for this, we use the Unified Parkinson's Disease Rating Scale, which is abbreviated UPDRS. And in this case, we give a score to a variety of different features that we can see in Parkinson's. For example, we look at someone's facial expression. We listen to how clear their speech is. We check their muscle tone. We look at tremors in the face and in the hands in different positions. We see how easy or difficult it is for a person to stand up and how good their walking is. And we also rate their ability to perform rapid, repetitive movements, such as finger tapping, where the pointer finger meets the thumb repeatedly. Prior to Parkinson's, people can do this quite easily, opening wide each time and with a nice rhythm. But once Parkinson's starts, it's harder to open up full each time, and we see that the fingers get closer and closer together. And the tapping might also become irregular. So those are the types of things we look for on Parkinson's examination. Now, while symptoms and disease progression can be different from one person to the next, many people advance in the same general pattern. And this progression has been conveniently divided into 5 stages with the commonly used Honyar scale. In stage 1 of the Honyar scale, it's the earliest stage, symptoms of Parkinson's are mild, so that they often go unnoticed as they don't interfere or they barely interfere much with daily activities. And they only affect one side of the body. These symptoms might include tremor, which initially may only occur intermittently, for example, when someone's just a little nervous. Other people might just notice some stiffness, or they might feel less coordinated on the affected side. Walking might be a tad slower, and maybe the posture is slightly bent. And people might notice a slight loss of facial expression as well. In stage 2 of Honyar, all of these symptoms are a little bit worse and more noticeable. And these symptoms now affect both sides of the body. And at this point, people may also notice that the speech might be a little more quiet and slurred, and the words might be more muffled. And a person in stage 2 might find that certain tasks are a little more difficult, or they take just a little more time to do. Now, people in stage 3 move slower, but the major feature here is imbalance, with people falling down. And while people in stage 3 are still fully independent, activities like getting dressed and eating are a bit more difficult to do. In stage 4, Parkinson's is disabling. And many people at this point will be using a walker. And as people at stage 4 need help with some tasks like bathing or getting dressed, they are no longer able to live fully independently. Stage 5 is the most advanced and debilitating stage. There's a tendency to freeze and stumble when trying to stand up or to turn around. And most people at this stage will spend much of their time in a wheelchair. Now, Honyar stages 1 and 2 are considered early Parkinson's. Stage 3 is the middle stage, and stage 4 and 5 are considered advanced Parkinson's, as these signify a loss of physical independence. Now, note that many people with Parkinson's never actually reach advanced stage disease. The length of time to pass through the different Honyar stages is going to be different from one individual to the next. One study found, though, that on average, generally people will go up a stage every 2 years, except for stage 2, where people stay for around 5 years on average. Another study found that 1/3 of patients stayed at early stage Parkinson's, so stage 1 or 2, for up to 10 years. And indeed, in clinical practice, we often see that many patients will stay in this early stage 1 or 2 for a prolonged period of time. Now, when people progress to stage 3, meaning that they're falling, this is a significant milestone for them, and it is associated with a reduced quality of life. Now, with people who have had Parkinson's for 15 years, around 80% of them will have recurrent falls. People who have had Parkinson's for longer, like 18 to 20 years, most of these people will be using a wheelchair because of the frequent falls. Now, risk factors for falling in Parkinson's include being 70 years or older in age, being diagnosed with Parkinson's at an older age, and having Parkinson's disease dementia, in which case people are 3 to 4 times more likely to have recurrent falls. Now, note that in many cases, we can reduce falls by doing physical and occupational therapy and with the use of walking aids like canes or walkers. And in addition, falls can also be reduced with one of the medications that we use for Parkinson's dementia, namely donepezil and rivastigmine. Now, you may have noticed that the Honyar staging system only deals with the main Parkinson's motor features, which are the shaking, the slowness, the stiffness, and stumbling or imbalance. But what about the non-motor symptoms? These are very important, and these include a variety of symptoms, including sleep disturbances, psychiatric symptoms like anxiety and depression, cognitive impairment, and what we call autonomic dysfunction. So these include symptoms like constipation, urinary incontinence, and orthostatic hypotension. That's just a fancy term for when the blood pressure drops after you stand up. So when people are lightheaded when they stand up. Now, these non-motor symptoms often start years before the motor symptoms do, in what we call the Parkinson's prodrome, or the pre-motor phase. And in some cases, these non-motor symptoms can start up to 20 years before the motor symptoms, notably constipation, which can start up to 20 years early. I think I said that. Now, other early non-motor symptoms include hyposmia, which is a fancy way of saying poor ability in smelling, depression, and rapid eye movement, or REM, sleep behavior disorder, which we abbreviate as RBD. This is when people are acting out their dreams and talking in their sleep. It's extremely common in Parkinson's. One study suggested that around 50% of people with Parkinson's has RBD, but this is thought to be an underestimate. Now with RBD, especially if you have it early during that premotor phase, it is associated with a faster progression of Parkinson's. Now, another one of the non-motor symptoms that we often worry about is the cognitive decline. Many people with Parkinson's will note early on in the disease that they might have some slowness to their thinking. And this gradually will worsen over time, along with difficulties with multitasking, problem solving, trying to stay focused, and even coming up with the right words in conversation. Ultimately, a quarter to half of people with Parkinson's do develop dementia. But this goes up to around 85% if we only look at people who have had Parkinson's for 18 to 20 years, or who are at least 90 years of age, regardless of how long they've had the Parkinson's. And if the dementia isn't bad enough, we also see that it's associated with having psychiatric symptoms. So people with Parkinson's disease dementia will often have apathy and depression along with it, and 3/4 will have hallucinations. This is when you see, hear, or feel something present when it's not actually there. The biggest risk factors for Parkinson's disease dementia includes, again, being over 70 years of age, again, being older when diagnosed with Parkinson's, and not having a prominent tremor, which is what we'll talk about next. So Parkinson's motor symptoms differ between individuals. So we sometimes categorize people based on their motor subtype, so that they can either be tremor dominant or non-tremor dominant. And as you can guess, the tremor dominant folks are those whose first symptoms, their motor symptoms, are a resting tremor, which means that their hand is shaking or their leg when it's just resting on their lap or on something, on a surface. Now, this is compared to folks whose first symptoms are not a prominent tremor, but instead might be slowness or stiffness. And they don't have a prominent tremor. So the tremor dominant folks tend to have a more benign disease. They worsen at a slower rate. Their balance and walking tends to be better, and they have less non-motor symptoms. So they have less dizziness when they stand up, less depression and apathy, and they also have less cognitive problems. So they're less likely to develop dementia. Now, all of these features are more likely to be seen in the people who are non-tremor dominant, the people who are just stiff and slow. For example, people who are non-tremor dominant are 4 times more likely to develop dementia. Oops. The cause of these differences seems to stem from the underlying pathology being far more widespread in people with the non-tremor dominant Parkinson's compared to the tremor dominant Parkinson's. But over time, many folks who have the prominent tremor will start to look like the non-tremor folks. This actually occurs in around half of people within 5 years of diagnosis. And in one study, people who have had Parkinson's for 15 years, only 11% of them had a notable resting tremor. Now, while many folks are happy that the tremor has resolved over time, we see that this change, this resolution of tremor, can actually be an indication of disease progression, because typically it's only after the tremor goes away that people start noticing problems with their balance and maybe some cognitive problems as well. Parkinson's progression is also partly dictated by the age at which the motor symptoms started. Now, we don't have a specific cutoff age between young versus old Parkinson's, so it's better just to consider it on a spectrum, if you will. And in general, people who develop Parkinson's at a younger age will have a less aggressive disease. They progress slower. Their balance is better, and they have relatively less non-motor symptoms, less lightheadedness, less cognitive impairment, and they're also much more likely to get a dramatic benefit from the Parkinson's medication. But they also have more problems with dyskinesias and motor fluctuations. We'll talk a bit about that in a second. Now, in contrast, people who have Parkinson's at an older age, they worsen quicker, and they are slower moving, and they have worse balance. And of course, it doesn't help that many people who are older tend to have other medical problems, potentially contributing to the balance issue. They're more likely to have more likely to have lightheadedness, cognitive impairment leading to dementia, and they're less likely to get a good response from the medication, and they're less likely to have the involuntary wiggling movements, the dyskinesias. Now, the reason for this is that it seems that the brain's aging process itself seems to interact with the Parkinson's disease process, making it that much worse in combination. Now, having said that, the connection between age of disease onset, the age that you started with your Parkinson's, and that rate of disease progression is only true in general for people with early and mild and middle stages of Parkinson's. Once we hit advanced Parkinson's, progression seems to be the same for everyone, regardless of how old you are when you started your symptoms. 25% of people who have had Parkinson's for 10 years will be considered at advanced Parkinson's. And for those who have had Parkinson's for 15 years, 50% will have advanced disease. And one study noted that after having Parkinson's for 20 years, most people were living in nursing facilities, with the main predictors for moving to a nursing facility being hallucinations, falling, and dementia. Now, as Parkinson's symptoms progress, the treatment regimen evolves along with it. In early Parkinson's, when people only have mild symptoms, generally the Parkinson's medication can be taken just 2 or 3 times a day, and for most people, they'll notice a significant benefit. Many people will feel normal or stable during what we call this honeymoon stage. But over time, we start seeing complications. And the treatment of complications itself generally adds complexity to the drug regimen, which of course is an added burden to patients and caregivers alike. The first one of these complications to occur is what we call wearing off. And in this case, the benefit of the medication dose doesn't last as long as it used to, such that a person's symptoms periodically worsen before they get their next dose, and generally in a predictable fashion. Now, this often results in people needing to take their medication more frequently. And for some people, they end up taking their medication every few hours due to this frequent wearing off. Another common complication with Parkinson's medication, notably the levodopa, is dyskinesias, which is an uncontrollable wiggling-like movement that some people have, often in stage 2 and 3. But over time, it generally fizzles out, so it rarely becomes a problem in people who have advanced Parkinson's. But if the dyskinesia is bothersome, there are generally treatment or medication treatment regimen can be adjusted to help with that. Now, in the advanced stages of Parkinson's, we can see dose failures. And in these cases, it means that the benefit of the medication can just stop working suddenly, unpredictably. Oh, actually, sorry, I got them mixed up. So dose failures where the medications just don't work at all, and then sudden offs when the medication just is unpredictably stops working. Okay, we do have some what we call rescue medications that can sometimes help with this to an extent. Now, also in advanced Parkinson's, often the levodopa just is less effective. It doesn't work nearly as much as it used to the extent that one study found that only 20% of people with advanced Parkinson's got over 30% improvement in their motor symptoms from the levodopa. And half of people with advanced Parkinson's saw less than 15% improvement in their motor symptoms when they took the medicine. So it doesn't work great in advanced disease. And the other issue confounding this is that often we actually have to reduce the dose of levodopa because in advanced disease, the side effects tend to be more noticeable. For example, one study noted that a whole third of patients with advanced Parkinson's had moderate sleepiness from taking the levodopa. And of course, it can also cause that lightheadedness on standing up. And the most worrisome symptom, I think, or side effect from the medication that we see in advanced Parkinson's is hallucinations. Thankfully, we do have some treatment options available for this complication as well. Now, here's a summary slide that puts together everything I talked about, hopefully. So including the non-motor, the motor symptoms, as well as the treatment complications that we see. And just to get you oriented, the line on the bottom is just years of progression. So starting with 20 years before the motor symptoms, we can start having those non-motor symptoms, which I've written here in blue, and you can see that gray background. And then at year 0, that's when your motor symptoms actually start. And that's in red and the pink background here. And then a few years later, we start seeing some treatment complications, and those are highlighted in green. So hopefully some of this presentation has been helpful for you. I want to thank you all for your attention. And now I'm going to kick it over to Lance.
Thank you.
I can stop my sharing.
There you go. Thank you, Dr. Killoran. Hi, everybody. My name is Lance. I am the social worker as well as the outreach and education coordinator at Thomas Jefferson University's Movement Disorder Clinic. And I'm here to kind of supplement what Dr. Killoran was mentioning earlier, speaking to more so some of the clinical things. So I'm actually going to go ahead and share my screen so you guys know what I'm talking about. All right. All righty. So again, I'm Lance. I'm at the Jefferson Movement Disorder Clinic, and we're going to talk about kind of do some supplemental conversation in regards to kind of the other side of the clinical things in regards to progression. So just a quick overview of what I'll be talking about today. Pretty much, we're going to just go over the practical things, Measurement is important in this disease, so we're going to go over some measurement options. We're going to have a conversation about some of those harder conversations to have, as well as what you can do for your self-work, your maintenance, and then just go do a quick look at some resources and benefits that are outside of the Parkinson's Foundation. All right, so the practical stuff are the things that we know about already. So typically for people who are involved in this disease, typically you hear all of the information around, you got to exercise, you got to do therapy, you have to make sure you're safe, and, keep moving. So of course, that also leads to possibly the introduction of some durable medical equipment, so such as a rollator or a walker or a cane or walking poles. Also home health, so those home therapies or maybe those home health aides that might come in to assist with some of those activities of daily living, as well as levodopa, other medication options for treatment, and of course, your typical neurology follow-up. So the first thing that's important is it's very hard to measure progression if you don't have a measurement option for it. And so how do we keep tabs on making sure that we know what's progressing, what that looks like, and what that means specifically to your case or your loved one's case as they navigate Parkinson's? And I think the most important thing is the development of a baseline. So a lot of times when people are newly diagnosed, we'll mention, hey, you might as well get a full workup, physical therapy, occupational therapy, speech therapy. And sometimes people are a little bit resistant because, I don't have any speech issues. I don't have any issues with that. I don't work anymore. You'd be surprised how many times I hear I don't work anymore, so I don't need occupational therapy. But occupational therapy is more so looking at those activities of daily living, those cooking, cleaning, bathing types of activities that can be modified if necessary. So the reason I bring that up is because the development of the baseline is one of the most important things. We can't, as providers, best help you to figure out where you're going if we don't have an understanding of where you are currently. So what that means is that typically once you get diagnosed, what possibly or could be happening is a referral to a whole lot of other services. So typically the social worker, such as myself, or a mental health provider might be involved because this is a traumatic diagnosis to be diagnosed with. And I think that oftentimes it happens in the midst of life. So it's kind of like, oh, I have to pick this up and go. And you don't really get a chance to really process what's happening. So that would be a great referral for a mental health provider or a social worker to have that conversation, as well as physical therapy, occupational therapy, speech therapy, to identify where you are currently so we can attack or address some of attack some of those issues that might arise in the midst of as you progress. So, of course, that means also possibly being referred to neuropsychiatry or neuropsychology, rather, in order to develop a baseline of cognition, if that's a concern, as well as the other individuals that work closely with your movement disorder specialists, such as the nurses, the nurse practitioners, and physician assistants. So why is this important? Why do we need to develop a baseline? And I think I mentioned, of course, it's important to figure out where you are, but ultimately, and I think that someone had mentioned or submitted a question in regards to how do I create a care map? This is exactly it. You get a baseline of where everything is currently so that you can address it moving forward. And the sooner that we can identify an issue, the sooner we can start creating an intervention or some type of plan to address those things. So with that being said, I'm going to move into some of the harder conversations to have. Typically, these are things that possibly or should possibly be addressed with your movement disorder specialist, but everyone doesn't always feel comfortable mentioning these things, or they feel like there is a shame that is surrounding some of those issues. And I think that one thing that I try to lay out, and this is for all patients that I come across with, as well as care partners, is that this is your healthcare. You drive this. So if something is bothering or something is aching you or something is kind of in the way of helping you live your your best life with Parkinson's, that's something that is worth mentioning so that we can, help you figure out some type of way to adjust, or maybe there's something we can do to treat it. So the things that I see more common that people don't necessarily feel comfortable sharing are when they have misperceptions or possibly hallucinations. So that could be as easy as waking up and you have a pile of clothes on the chair across the room and you think that someone's sitting there. That's very common, as well as, okay, there was a sock on the floor and you thought it was a mouse. So those misperceptions are very common, as well as possibly developing hallucinations where you see things that are completely not there. Those are things to mention to your movement disorder neurologist. And as it was mentioned previously, there are medication options, as well as possibly, making sure that we can adjust your medications or adjust your therapies as necessary. Some of the other things that people don't necessarily want to share are some of the more intimate things. So, and I had the pleasure of that, and I think the Parkinson's Foundation for this, when I went to an LA team training, I got to meet a sex therapist named Gila. And she was amazing, because one of the concepts I never thought about was that sometimes when individuals navigate from partner or spouse to care partner, some of that intimacy is lost. So that prompted me to have more conversations about how people's home lives are and what it is that they feel as though they need to either, kind of get that back, or maybe there's some physicality issues in regards to maybe there's some other medications that need to be introduced to offset some of the issues that might be happening more on the intimate side, because intimacy is ultimately something that every human needs and wants and desires. And if there's something that we can do to make sure that people have that, then that is ultimately what to do. Now, there's a slew of other issues that come up, but one of the things that I mention all the time is this white coat syndrome. And that's usually referring to people putting on this grand production in front of their movement disorder specialist. And I can't tell you how many times I've received calls where the appointment was great. There were no medications changes needed. There was nothing, needed to be added. And then I get a call from a care partner in the car saying, oh goodness, it was just terrible. Everything presented so well and then just fell apart when we got to the car. And so I call that white coat syndrome, because the issues that are often seen on the day-to-day, your movement disorder specialist has a few minutes to kind of assess and address those things. But if those things are not present at the time, it's very hard to address them in the moment. So that's when you start, kind of relying on the other members of the team to kind of help offset some of those issues. One of the biggest things is disclosure. And I've had many conversations in regards to, do I tell certain family members? Do I tell my friends? Do I tell my employer if I'm still working? And instead of it being more so like hey, I have to come out to these people. I have to come out and have a conversation about my diagnosis or my status and my health. You're letting people in. So I think that it's important to change the narrative and change the wording around that, because it's you are the center of your story, right? You're your main character. So you ultimately are letting other people in onto your story. So I always tell people, you have to do what makes sense for you. If there are concerns about possibly losing jobs or things of that nature, then that might be a reason why you wouldn't disclose. Well as in other ways, if there are family members that, might take it hard or things like that. No, don't get me wrong. I'm not saying you don't need to build a care team, and I'm not saying you don't need to build other care partners. But what I'm saying is you know your life best, and who would be able to kind of stomach these types of things. And sometimes you'd be pleasantly surprised. But ultimately, you have to do what makes sense for you in regards to letting people in and become a part of your journey throughout Parkinson's. It's not the type of disease that you want to isolate yourself for. You want to build up a team of peers and loved ones and individuals that can be in your corner when things might get tough. And then the last things that are one of the harder conversations to have is when requiring more assistance. So you need more help doing things that you could previously or possibly do in 20 seconds. Now it's taking you, let's say, 5 minutes. That can be sometimes normal. So I think it's important to start having questions about what your desires are in regards to long-term planning. Does that mean you want to age in place? Do you want to age in home? Would you be open to having some people, if your care partners aren't able to meet all of those needs, would you be open to someone coming into the house and having some additional assistance with those things? Maybe talk about facilities. Maybe that's not something you want to talk about right now, but I promise you it's better to start the conversations as opposed to having to address them later on down the line when everything is kind of thrown onto the table. And I think one of the questions we got is care partners were asking, do I help? If I notice that my individual with Parkinson's is struggling with, doing something, do I help? Do I do it for them? Do I intervene? And I think the answer, the best rule of thumb to go by would be let them ask you. So there's something very stressful, and it's a grieving period that happens when you lose abilities to do things that you could typically do previously. And the one thing that you don't want to do as a care partner is to intervene in a way that is going to amplify those negative emotions, because then that could possibly cause rifts in that relationship. And we're going to talk about that in a little bit. So self-work and maintenance. So this is kind of like the opposite side of all the clinical stuff, right? So this is more so the human stuff, because these are individuals, these are people living with Parkinson's, whether you're a care partner or a patient yourself. These are things to pretty much remind yourself of often. So how you feel is valid. That's the first thing. And I think that, this has become a phrase that people kind of throw around now, but it holds true. How you feel is valid. If you feel frustrated, or maybe you had a really good day yesterday, but today's not so good, that's okay. You have the ability to navigate and have emotions. You're human. So how you feel is valid. And I think that if people were to take that on as a mantra, and how they feel makes sense. How you feel makes sense in the moment that you feel it. And that's okay. And then I kind of talk to people about leaning in versus the spiral. So leaning in is being able to sit with your emotions, being able to sit and be able to say, okay, I feel this way. Okay, if I really want to do some work, do I know why I'm feeling this way? Okay. And if I do feel this way, what do I need to get out of this funk? Or what do I need to do to kind of boost my mood? These are all questions that individuals, if they take a moment, and some people do meditation, some people do prayer, but if you just take a moment and check in with yourself, you're able to have these internal dialogues that ultimately might be able to improve how you're feeling throughout the process. And I think that one of the great things about meeting with a mental health provider or a social worker up front or near the beginning of diagnosis is that some of these interventions, some of these tools and strategies for checking in with yourself are the things that people sometimes don't get until mid or later in their disease state. And it could have made a world of difference if this was something that people were practicing prior. And I told you guys about leaning in, but I also want to mention the spiral. So the spiral is a term that I use when discussing when thoughts are just moving way faster than people can stomach them. So the spiral is when people are like, I think about this, and then I moved on to this thought. Oh, what about this? Oh, what about the kids? What about the animals? Oh, what about that appointment? How am I going to get there? It can be very overwhelming. And it actually is probably the base of most of the anxiety that comes along with this diagnosis. You're trying to cognitively move quicker than your brain is actually able to keep up with. and that can cause angst and anxiety. So the one thing is that when you notice that you're spiraling, the easiest depiction of that is I think of a plane that's nose diving. When you're in the spiral, you need time to calm everything down and almost pull yourself back together. And that's fine if you need help to do that. And I don't think that's said often enough. But I'd also want to point out that this goes for care partners as well. This is a thing that every human can practice. This is not specific to the individual with Parkinson's. This is also specific to the care partners, because this is a family disease. This doesn't affect just one person. It affects the entire dynamic. And I think that if people kind of took that thought process on up front, it might alleviate a lot of the stressors that come on later on down the line. So these are just things to keep in mind as you navigate this disease, because there's no quote unquote right way, or there are better ways than not, but there's no one's going to be able to tell you what looks best for your specific Parkinson's journey, because we're all unique as individuals, and the Parkinson's disease progression looks different for pretty much everybody you meet. So in continuation of self-work and maintenance, of course, I had mentioned earlier, those rifts if you don't address your emotions. So being mindful of those emotions, because it's very easy to project those emotions onto your care partners. I think one of the most frustrating things for a care partner is when they just want to do whatever they can do to help, and there's aggression or some negativity and emotions that's being given to them, and they don't know how to navigate it. So this goes for both care partners and individuals with Parkinson's, to be mindful of your emotions. And that's not always something easy to do in the moment, but being able to engage in dialogue and conversation, I think would stop a lot of resentment sometimes that builds. And this is just typical human stuff. If we felt as though someone was speaking to us a specific type of way and we felt disrespected, or we felt a certain kind of way, sometimes, we can chalk it up to whatever was happening in the moment, but other times those conversations need to be addressed. Sometimes it's more so looking at the mending of the dynamic in the relationship, as opposed to blaming everything on the disease, because sometimes it is the disease, but other times it's the human component. So of course, following up with therapy is a great idea. Mental health providers are definitely at an all-time high in regards to need right now. Because I would be amiss if I did not mention the effect of COVID in all of this, and quarantine and all of this. That has definitely cut away a lot of people's socialization, has actually created a lot of anxiety and depression in individuals. And that's not something that people should be ashamed of or feel like they should have to address on their own, when there are trained professionals that can help you address these things. And if necessary, then maybe looking into a psychiatrist. Maybe there's some medication interventions that can be done. I do typically tell people, if you're I would recommend you do both, of talk therapy as well as psychiatry. But I also like to tell people that if you are going to see a psychiatrist that is not necessarily familiar with Parkinson's disease, just make sure that your psychiatrist and your movement disorder neurologist have a relationship, or at least know of each other, just to make sure that there's no contraindications in regards to medications and things of that nature, because not all medications play nice with an individual with Parkinson's disease. Now, quick jump into resources and benefits. Of course, the Parkinson's Foundation is a great resource. I think when I first got into Parkinson's, I think I just lived on their website to kind of dive into all of this information, and it continues to grow. But some of those things outside of the Parkinson's Foundation are possibly talking to your provider about a palliative care consult. And that can happen on an outpatient basis. There's a lot of geriatricians that also specialize in palliative care, as well as neurologists. Some neurologists specialize in neuropalliative care. And the one thing I just want to take a moment, because sometimes when people hear palliative, they think of hospice. And I just want to differentiate that. The easiest way to say it is that hospice is a type of palliative care, but palliative care is not necessarily hospice. So, and why would someone want a palliative care consult? Typically, it can look at your process in regards to ultimately the ultimate thing is helping you live your best life, helping you live your most productive life. And if that means, you know, there's some meds that are not doing what they're supposed to do for you, or cleaning up your med list, or possibly getting you tied into other resources that might be more related to you aging, or more related to making sure that you live a healthy and prosperous life, that might be something that a palliative care expert might be able to assist you with. And typically that happens on an outpatient basis, but there are in-home providers typically attached to home care agencies that can provide this palliative care. Of course, palliative care is also sometimes having those more uncomfortable conversations. So things that come up such as advanced directives, living wills. What do you want if you are in a place in which you are unable to make those decisions? People, these conversations get very uncomfortable, but I promise, if you have these conversations up front, they just take out a lot of emotional baggage and a lot of emotional drainage for you and your loved ones in the situation that, and this is not strictly for Parkinson's patients, this is for anybody. Because we know that Parkinson's, for the most part, typically is a more slow progressing disorder. But this goes for everyone in regards to making sure that, you know, some of those things are kind of addressed so that you don't have to address them in the moment. Of course, you have your local office on aging and disability, which is great for getting some of those non-skilled home care services. So the home health aides are the people that can possibly help with those activities of daily living. So that cooking, cleaning, bathing kind of portion, if that is something that people get to the point where they're unable to do it themselves safely, or their care partner needs some additional support, that might be a good place to start to find out what local resources are available, as well as possible resources in possible grants for home modifications if necessary. Of course, you have elder care attorneys, which can help with financial planning and kind of figuring out where to make sure the finances are handled. And of course, going back to living wills, advanced directives, those things. Of course, the Medicare.gov website is a great place to look up different providers, as well as home care agencies, go over some Center for Medicare and Medicaid Services, or CMS's guidelines. I can't tell you how many times I get the phone call that, oh, my Medicare will pay for non-skilled services. I've had this conversation probably about 3,000 times in the last 2 weeks. I'm joking, but it comes up a lot because people will read home health care and it won't differentiate skilled care versus non-skilled care. And home health aides and home health assistants is typically falling on the non-skilled side. Another great resource is, I'm biased because I'm a social worker. I will always be biased. I love this profession, is going to be access to social workers. So for those who are near institutions where you can access a social worker, or a hospital, or one of these centers of excellence, or someone in the Center of Excellence network, there are many institutions that have social workers that can help you kind of navigate some of these things and tend to some of these issues that might come up. Because I know that in this short time of me talking, some of this stuff is probably, Greek. But also you can always check with your insurance company, especially for individuals who have those managed care plans. A lot of them have care coordinators or social workers that can help you and have no problem contacting doctors' offices for paperwork and helping you kind of build your cases for certain things to have the insurance cover them. Okay. And overall, so this is if you take nothing else and everything I said was gibberish, the one thing I want you to take from all of this is that your outlook and your engagement and your wellness will shape the trajectory of the PD continuum. So how you view and how you navigate and the emotions that you are constantly processing will ultimately shape how you feel as you go on along your journey with Parkinson's. And that, of course, applies to both individuals as well as the others. So, of course, be kind to yourself. This is not an easy disease, and this is not something that most people would know how to navigate in the midst that they have to. So if you are making it up as you go, there are supports, but I promise you don't have to. And that is all I got.
Thanks very much, Lance. I really appreciate your comments. And if we can bring on Dr. Annie Killoran's video, that'd be great. Thanks. So really interesting presentation. We have had almost 2,000 people join in, and people are at all different spectrums of their disease. I think it'd be great to just emphasize, because this is a lot of information for some people. Others have been living with it for a while, but and I think you both can weigh in on this. But Annie, perhaps you first. People are concerned about Parkinson's disease. They see this progression and they're thinking, what does it mean for me? Parkinson's is a tough disease. I don't think we can sugarcoat it, but I think we can say it's not a death sentence. Would you agree?
Yes and no. So life itself is a death sentence, right? All of us will have our final journey, so to speak. Parkinson's doesn't itself kill you, but it's associated with increased mortality in the advanced stages. For example, you're more likely to have pneumonia when you have Parkinson's disease, and that pneumonia could ultimately lead to your demise. Similarly, in advanced disease, you can fall, break a hip, end up in the hospital, and have complications from that per se. So people can have many great years with Parkinson's, and for some people, they don't develop advanced disease. But if we do have advanced disease, then often there is, the complications aren't great. Sorry.
Yeah, no, I understand. Lance, anything to add? I mean, what do you tell the the people living with PD that you see in their families?
So typically I will never, or I typically shy away from the thought that it's a death sentence, because I think like the doctor mentioned that, just us living is ultimately we're all going to the finish line at some point. And I think that typically as much as I can, if I can get people to reframe that thought process of, instead of looking at it as a death sentence, how can we look at enhancing the living experience, right? So instead of it being, okay, this is my mortality speaking, that's an anxious and depressing response. I mean, it's something that people have to navigate. But typically I tell people, let's reframe it as to how can we live now and enhance that living experience as opposed to focusing on the end.
Yeah, absolutely. So thank you for that. Annie, you had a really useful description of stages. And I think it was useful to know that, people with young onset Parkinson's disease have a slightly different experience than those who are others. Have other experiences. Dyskinesia and other issues are concerned for people, especially for people who may be new to PD. What's the thought about prescribing levodopa or dopamine replacement medications earlier rather than later, and how might that affect someone's progression and their ultimate quality of life?
Oh, that's the million-dollar question. So there's been a lot of controversy over the years regarding, do you start levodopa early, knowing that someone might have dyskinesias from it, notably in young folks? Or do you wait and use other medications, holding off on using the levodopa, knowing that you can have problems with that? I think, so I generally carry a chart with me in clinic to show my patients who are young onset Parkinson's disease, because they're the ones that are more likely to have the dyskinesias. Bottom line is levodopa is the best drug we have. Starting it early, you'll have great response. It does great for your symptoms, but you are going to be at high risk or higher risk for the dyskinesias. So people can start the other medications like the dopamine agonist, for example, knowing that we can add on low doses of the levodopa as we need to. You know, so I didn't answer your question. Both ways are totally acceptable. I think it's worthwhile to have a full discussion with your provider to talk about what makes you nervous about starting the treatment. In general, I would say a lot of institutions are going with the levodopa first, being aware that at lower doses, you're less likely to have it if you're just conservative with your dosing.
Yeah, and I think it's important to emphasize that many people, maybe even a couple of years ago, felt it was the big gun to be saved for later. And would you suggest that's still the case, or is it, because it seems evidence from many studies show that the quality of life and even longevity is increased by earlier replacement of dopamine than not.
So I would recommend definitely starting something. And for people who do have side effects on an agonist, by all means, switch over to levodopa. Don't hold off or anything. But some people do great with the agonist and they don't need the levodopa for a while. Other people don't do well with it. They get sleepy. They have, impulse control disorders. Try the levodopa. If it helps you, great. And yeah, there's a shifting thought amongst providers, and it also depends on where you've trained. The research, though, I will mention, often when they talk about the dyskinesias that you do get with levodopa, they often describe troublesome dyskinesias. So it doesn't talk about a lot of the people who have the moderate dyskinesias, which can also be. So it's a word. It's the wording. That's all. I would say before anyone starts treatment, just talk to your provider about the pros and cons of either. Just knowing that you can change your mind if one doesn't suit you. There's lots of options for you.
And I know you have to go in just a minute, but I just wanted to get one last question in, if I could, about your risk factors for dementia. This is another concern from our population, as you can appreciate. When you talk about older people, what is older? So this is a question, and that may be difficult to say. So, but to the extent we can, recognizing that everyone's PD journey is really a unique journey in many respects. What can we say in generalizations?
Yeah, so that's a tough one. So we don't have a cutoff for what's young versus old. A lot of people start having their Parkinson's around age 60. Just if you're older than, I don't know, say, I hate giving out a number because everyone's going to clasp onto it. Just see it as a spectrum, all right? So if you're a young fella, if you're in your 30s, that's definitely young onset. If you're 80, it's definitely, mature onset, if you will. Yeah, I'm going to refrain from giving you a number. I'm sorry. It's just, I can't do it. Just because also people age differently, right? If you have multiple comorbidities, you're a smoker, you have high blood pressure, your brain is older per se than someone who's had a very healthy lifestyle, who's been jogging and keeping trim their whole life too. So the brain ages differently for different people. It's another reason we don't like giving a hard cutoff for young or old.
And then one final question, because you bring up another issue I think that's related to progression in many ways. Recognizing we ultimately can't stop the disease, but improve quality of life. What do you tell people about exercise?
Do it. Absolutely. And I hear from all of my patients who regularly exercise, they feel so much stronger and they feel in better control with their Parkinson's symptoms. And some of them will fall off the wagon saying, oh, I haven't exercised for 2 weeks. My Parkinson's is so much worse. They start up the routine again and they feel better and they're more controlled. So definitely we recommend it. And there's a lot of evidence to suggest that it might actually slow down progression. So, hey, and it's good for all your other medical issues. It's good for sleep, for your happiness, etc. So please get out there, move as best you can. I realize that some people are limited by their balance problems. You can still, do weights from a wheelchair. You can do yoga. You can get on the floor and do leg lifts. You can go to a pool perhaps with a safety belt. Okay, it doesn't have to be, you don't have to run a marathon. Just do what you can.
Yeah, absolutely. And I know that the foundation has lots of resources on different types of seated exercises versus others. A stationary bike is one way. I know that people who like to go outside, there's adult tricycles. They're just 3-wheelers. They're really actually kind of cool to get out there, because I like biking. So I think that's really helpful. So I know you have to go see a patient. So thank you very much, Dr. Killoran, for your time. And Lance, if you can stay on for a couple more questions, I'd love to just follow up with you on some others. Thank you.
Sure.
So I think you mentioned something that's really important, and that Parkinson's is a family disease. It affects many other people. How do and you talked on some levels on how family members can get involved, but if you want to elaborate on that, that would be great. In particular, I'm curious, as you mentioned, those tough conversations. Family members see issues that maybe a person with Parkinson's doesn't want to see. I imagine they see them too. How do they have those conversations with them? Because I think if you said that being able to address these things early will probably make everything else a little easier, because it's weighing on everyone's mind, regardless of whether they want to face it or not.
No, I think that's a great point. I think the first thing is education. I think a lot of the I'm going to bury this. This is not really a thing. That didn't really happen. Or I'm not going to mention it to the doctor, are all things that kind of stem from almost a miseducation or a misinterpretation or a lack of knowing. So I think on the family side or the care partner side, what they can do is make sure that the information is readily available. I think you want to make your person or your individual with Parkinson's feel like they're not the abnormal person, right? You want to make sure that this is something that happens. You want to normalize their experience, because once they understand that this is something that typically happens, this is something that happens a lot in Parkinson's, it then puts them back in the driver's seat to bring it up to the provider. Because when family members or care partners start having those backdoor provider conversations, that can create some distrust in the medical relationship. And ultimately, we want our individuals with Parkinson's to feel very calm and safe and intentional about having their appointments with their neurologist.
Yeah, absolutely. And I particularly think about, as you mentioned, sometimes the misperceptions people have. They can be visual misperceptions, the sock that's the mouse. And we worked with a clinician who provided a nice video that's on our YouTube channel about what are called hallucinations, if you will. And what was I think important for our audience to recognize is that sometimes people have a little bit too much medication, and it's just scaling back can change that. So it's not because someone sees something that's the end of the world or that they're crazy. It's that maybe their medication's off, or it could be some other issues that it's important to talk to their clinicians about. And you also talk about, you're thinking about the family, you think about the care family, the multidisciplinary team, that's part of it. You're at one of our centers of excellence in Philadelphia. Thomas Jefferson's a great university. Not everyone has access to TJU's facilities, or to you. How do people find that care team and find, get the help that they need from, different providers? What would you recommend?
My recommendation is to start with the neurologist. So 9 times out of 10, of course, people are being diagnosed by a movement disorder specialist or a neurologist that refers them to possibly a movement disorder neurologist. Start with the people and the relationships that they already have in the surrounding area. If there are organizations that treat or address Parkinson's better than others, they would have the information for that, because they've probably in their practice have come across those individuals already. So I would start with the office in which you're getting treated, because there's a lot of local organizations that we have, even in the greater Philadelphia region, that people might not know to go to or wouldn't ever, try and contact until they knew that it's one of the community partners that we have that we feel comfortable having take care of our patients. So you don't have to create the wheel.
Yeah, I think that's a really good point. And, I also want to reiterate what you said during your presentation, which is that even though people may not feel they need these resources, it's good to get them checked in. I do know that one study looking at for people with for speech therapy, people who are newly diagnosed had problems swallowing that could be benefited from seeing a speech pathologist. Dr. Killoran mentioned exercise. Physical therapy is a good way to start, so they can tailor your exercise for who you are and what you can do. And seeing a physical therapist to get that exercise plan can be really important. I think you really bring up a good point. And the last is about, I think, if you want to just expand a little bit more about the outlook and how to have that kind of positive outlook, especially in time of COVID, is where we've always done expert briefings via Zoom, but that seems the way everyone can talk to these days to people. So, any parting comments before we have to, wrap up and say thanks to our audience?
Sure. So I think that first we got to address the elephant in the room. It's hard. It's not easy, especially if you have some type of ambulatory deficit or can't get to the places and get to the things that you ultimately wanted to do or did in the past. So I think the first thing is acknowledging this is not easy, and being able to have that realization to understand that there's no magic fix to this. This is going to feel uncomfortable regardless of how you navigate it. And that's COVID, and then the additional of the Parkinsons. So that outlook is hard to reach all the time, but I do encourage individuals to find what it is that find that enjoyable activity, find that safe thing that that, okay, if I can just make it through this day, at least I know when I get home that show is on, that my favorite show is coming on, or I'm going to be able to help my significant other cook or what have you. You have to sometimes kind of bookmark certain things in regards to your day, or because sometimes the day is too big. So maybe just the hour, survive the hour, and then we'll figure out what happens after that. That outlook is not an easy thing to reach, but it's something that you have to be intentional about wanting to be within you, because if you don't make the intention, then it makes it even more difficult to try and navigate emotions and what you feel as though. And it sounds cliche to say you make the decision to be positive. But in a way, you almost have to train yourself, is that when you start catching yourself going on those negative tangents and those bad thoughts and those toxic types of things, you have to check yourself and say, no, I'm not doing that. No, no. And you replace it with a different thought, or you replace it with the positive thing. And that's 101. And as to trying to change that mindset in those thought processes. Absolutely.
Thank you very much, Lance Wilson. Thomas Jefferson University, appreciate your time. And thanks to Dr. Annie Killoran from University of Iowa. It's been a great webinar today. I'd also like to thank our listeners. We had well over 2,000 individuals today listening in, also on Facebook. It's a fantastic audience. And remember that this presentation is going to be recorded, so you can listen to it later. Upcoming, we've got expert briefings, 5 more throughout the rest of the year. And in October, we're going to listen to Dr. Vanessa Hinson, who's going to talk about PD medications, what's new. So really look forward to that and hope everyone can attend. I also want to just mention some resources and support that are available for you. These are provided by the foundation. This is the support of the donor communities help make this available. We have an Aware and Care kit, which is really important to have, especially if you're considering having to go to a hospital for elective surgery or something that's more immediate. We have an excellent library of not only print material, but also audio material through our podcasts. And we have a webinar series, which is our PD Health at Home. Last but not least, I'd like to mention our PD generation study. There are many people who are interested in this, and I know there's a little oversubscribed, but we're working to fix that. But for those of you who are family members, this is something to encourage your loved one to participate in, to understand if they have a genetic form of PD. And our hope is that genetic trials, clinical trials looking to provide therapies that may alter the course of PD may be made available, and knowing if you have a genetic form of PD is important. Of course, there's our website, and last, our helpline, 1-800-4PD-INFO. My colleagues are there standing by, ready to take your questions, and they work incredibly hard to answer them. So, kudos to them. But before you go, one last thing I just want to mention: we have an online survey that will appear when this window closes. So when the webinar is over, a window will open up on your browser. We ask you to complete the survey, and we use that feedback and look at it very carefully to improve our expert briefing series. We've been doing this for over 10 years and always striving to make it better. So, and it requires your feedback to do so. So please do fill that out. And until then, I look forward to seeing you next month. Be safe, and we'll talk again soon. Bye-bye.